All right, well.
All right, it's on. Woohoo!
Welcome everyone to 2019. We're delighted to have everyone here for the program. 2019 has some exciting things that we've got in store for you. One of the first that we have is we have brought in a new co-chair that I'll be introducing shortly, Joe Skye. And go back to the first slide, please. First slide. So I wanted to just briefly spend a minute about talking about Joe. Next slide. All right, so this is a slide, so this is the first question of 2019. What is this slide? I will get the pointer here, and I'm going to show you, we're going to focus on, for 2019, global health in the world, and the planet as we know of it. And one of these items on the slide is the planet Earth. So if you can guess, you're probably right. Right over here is the planet Earth, seen from the outer solar system, and right next to it is the moon, and that's Bennu that is on the far right. So this is a photo of Earth from over 100 million miles away, and it shows the Earth at this point. The reason I showed this is because for the last year, we have had conference calls every Friday afternoon, and one of those individuals on the conference calls was Lieutenant Colonel Joe Skye here. Now, the reason I want to show you is the dedication. Here we are on the bright side, or the sunny side of the planet, at 2 in the afternoon when we have our conference calls, and where is Joe at that point? Nowhere to be seen on this photo. He's on the dark side of the planet, stationed in a turret in Afghanistan that is on the other side of the planet. To show you the dedication, we sat on our phones and at 2 p.m. start our conference call. Joe has to set his alarm in Afghanistan for 2 a.m. in the morning. He has to either get up at 2 a.m. for our conference call for RightCare initiative, or stay up all night so that he can participate in the conference call. What does this mean? To me, it means a lot of dedication. If you're willing on a busy day to set your alarm for 2 a.m., get up for just a conference call for just a couple of us, all the way from Sacramento, that meets the criteria that you should be named co-chair of the RightCare initiative. He's met the test, and therefore he is now going to be, for this next year, co-chair. Now, what we have here is the Earth seen over here. But we're going to get a little bit more focused. We're going to focus on a smaller area. So California here is about 1/3 the size of the moon that you see here. Kind of a third of that dot is California. And so we're going to focus one step further, and actually, I will now advance the slides. One more.
There we go.
To our next slide. So our next slide is now focused not on California, but in an even smaller area, and that is Sacramento. So our focus this year is going to be Sacramento. We zoomed in, and here's Sacramento on the river. And your current position is just to the left of the slide, right on the Sacramento River that we have outside here. So yeah, we're focusing on two things, Sacramento and the year 2019. So everything that we're going to address this year is going to be very important for reducing cardiovascular events, making people live longer in Sacramento. That's what we're going to do. And since it's a new year, we'll have New Year's resolutions. So we've all made New Year's resolutions, and if you haven't, let me know, because I'm going to give you a couple that you can make. And the couple that you can make is shown on the next slide here. So here are approximately 100 New Year's resolutions that we are making for RightCare Initiative and that you can make as well for it. The reason I show these 100 resolutions, these are the 2019 ways to live longer with the RightCare Initiative in California and in Sacramento. Now, I realize there's almost 100 things listed here, and you may not be able to do all of those today on your list of resolutions, but I can tell you these are important aspects. Every one of these has a study or expert recommendation showing that it reduces cardiovascular events or makes you live longer at that time. So these are all important. Now, they're not all randomized clinical trials, and some are consensus and other things, but each one of these items here has at least a study to support, and we're going to cover many of those areas this year in the RightCare Initiative to show you how Sacramento, there are ways, proven and accepted ways of reducing cardiovascular death, allowing us to live longer in Sacramento with the RightCare Initiative. And to get a start, if you're going to look here, today we're actually going to cover one of the issues here. Which is today's program, the pointer works right, is seen right here. So today's program is Stop Smoking. So we've talked about other things, obesity, blood pressure last time, LDL, other things. In this whole mix here is Stop Smoking. Stop Smoking is a very important issue for reducing cardiovascular disease, cancer, and allowing you to live longer. That will be the focus of today's program, and that will be what our next individual will be introducing our speakers for smoking cessation today. So with that, I'd like to welcome everyone for attending. We have an exciting year planned for you. And with that, I'd like you to give it up for our new co-chairman, Lieutenant Colonel Joe Sky, Chief of Cardiology at Travis Air Force Base, and give him credit for joining us now on this side of the planet. Dr. Joe Sky.
Thank you, Bill, for that wonderful introduction. I'm honored to do this, and I'm going to start with a challenge. And I'm going to take two of these. One is wash hands, and the other is flu vaccine. I'm going to propose that we make it socially acceptable that we smile as a greeting rather than shake hands. I've been told that infectious disease doctors have actually looked at this, and that shaking hands is something that if we gave it up and exchanged it for maybe a fist bump or a smile only, that we would do ourselves a service during the flu season. But I am speaking out of my expertise, so take that for what it's worth. I'd like to introduce our first speaker, is Neal Kohatsu, and he has a long track record of public service and preventiveness, being the first medical director for the California Department of Healthcare Services and a former medical director for Medi-Cal. And then most importantly, though, since 2008, he has been a technical advisor and an advocate of the RightCare initiative. And we're honored to hear his presentation today on how to improve cardiovascular health.
Thank you so much, Dr. Sky. And, I agree. I mean, if that isn't dedication, I don't know what is. And, Dr. Sky and I were actually at RightCare in Silicon Valley and share a lot of interest in, of course, cardiovascular disease prevention, but also in a broader view of population health, which we'll probably get into by the end of the day. Thanks to Dr. Balmer, our chair, or co-chair, and of course, thanks to Eddie Reese-Hanley, who I've worked with for a number of years, as was just mentioned. Without her vision of leadership and talking about commitment, we wouldn't have seen this rate reduction not only in San Diego, but we're going to see it statewide in avoidable CVD and mortality. So Patty, again, always hats off to you on keeping energy going in this noble effort. So it's great to see a lot of old friends and new friends and on this particular topic. I think we were doing a little bit of history taking, at least in my memory. I don't think we've covered tobacco, so it's great to get to the last of the major risk factors for the development of hypertension, as Dr. Balmer said. These are the session objectives. I won't go through all of them, except for to briefly note. I'm going to just focus in on the, was it not picking up?
Sorry, can I take the mic real quick? Sorry about that. We have a white BMW in spot number 69 of attendance, license plate 8AVC096. You'll need to move your car. Again, it's a white BMW, license plate 8AVC096.
Nobody stared at the person who has to go with their car. But they might tow it, so please do move it. So I'm going to talk a little background on the clinical and epidemiologic aspects of smoking and smoking cessation. I know this is old hat to many people in the room, but I think it deserves repeating, and you'll see why as we tie into the interventions. My colleague, Dr. Tong, who I will introduce from UC Davis, will talk about system approaches and quality improvement approaches to achieving reduction in smoking prevalence. And then, most importantly, we're going to focus in on an actual case study, which is what this is about. So, well, those are the formal for CME credit objectives. Our real objective, as it always is to reduce cardiovascular disease, morbidity, and mortality, improve quality of life, as Dr. Balmer noted, in the Sacramento region. So our goal is when we leave today is that we all feel collectively that we are in fact going to move towards that most important goal and objective, reducing smoking prevalence to reduce CVD, morbidity, mortality. So again, you're probably very familiar with these, but let's just go over it in any event. Smoking presents a risk for atherosclerotic disease in general, CHD in particular, stroke in particular, heart failure, all cause mortality, which you're well aware of, and of course there's a dose-dependent relationship. Not showing on the slide, it's important to remember that secondhand smoke is also a potent has an adverse effect as well, a cardiovascular disease risk. The new epidemic of vaping and e-cigarettes, we don't have enough knowledge right now to know what the impact is. I think there's certainly enough concerns that people taking up vaping to smoke, it may in fact reinforce use of tobacco. So there's a general concern, but relative to CVD risk, not enough is known with respect to vaping. As I said, we've touched upon lipids, blood pressure, diabetes, but we haven't addressed smoking, and so these are the major risk factors. There are other risk factors, as Dr. Balmer could relate, probably at least 10 or more, and we will at time, I think over time, get into those as well. But these are the traditional risk factors. They're potent risk factors, as this slide notes. A great increase in MI incidence. And from a population health perspective, it's important to think not only is that important as a cardiologist and on a one-on-one patient level when you're talking about smoking cessation, but smoking accounts for about a third of the population attributable risk for first MI. So it has a huge individual and population risk that we should be concerned about. Smoking cessation in cardiovascular disease is amazing. I first learned about this when I was in medical school and also when I was an epidemiology student, but it's very striking how quick the risk reduction is. In the space of a year or two, there's a huge reduction, and in a matter of 2 or 3 years, people who quit smoking, most of them approach the risk, at least for CBD, of a non-smoker. Cancer risk doesn't go to zero, it is significantly reduced, but this is just one of the huge benefits relative to CBD and smoking cessation. It's relatively rapid and it's a huge reduction in risk. I won't belabor this, but people often, even though we're familiar with it as an epidemiologic risk, what is happening physiologically. There's probably 100 different adverse impacts, but just a few of these, which kind of re-emphasizes why it's an important part of overall CBD risk reduction at the patient level and population level, is because there are direct adverse effects on lipids. Smoking is associated with an elevation of LDL cholesterol, triglycerides, and a reduction in HDL cholesterol. Elevates insulin resistance, generates free radicals, which is bad for both CBD and cancer probably. Sympathetic nervous system impacts, which ultimately affect the blood pressure. Increased carbon monoxide, which has adverse effects in those with CBD. And elevates inflammation, probably bad for both CBD and cancer as well. In one slide. Somehow it dropped out. I'll just mention it. As we get into the actual process of thinking about quality improvement ways of generating or improving our smoking cessation efforts, there are, I'm not sure how it got out of the electronic file, but it seemed to. There are a lot of smoking cessation recommendations in the printout, or probably on the website we'll have these, but I'll just run through them since the slide doesn't seem to be here. CDC has recommendations, just Preventive Service Task Force, Million Hearts Initiative, American Pediatrics, American Diabetes Association. These are just a collection. And most recently, just last month, the American College of Cardiology, December 2018, released some guidance. More or less it's in alignment, but it does give particular perspective to whatever your practice area or how you're thinking about it within your system. It's good to know that these guidelines are available. It must be in the wrong book. There it is, there was that stuff. Now, when we think about system approaches to smoking cessation, because more or less I think all of us are working in systems. Even if you're in a community clinic, you're often part of a system in that you have a contract with, say, a Medi-Cal health plan. I'm going to call it mixed, but the long name is Medi-Cal Incentives to Quit Smoking, and Dr. Tong is going to go into great detail about that project. Briefly, it was a 5-year project. She was a co-PI, was the PI of the project. It was a $10 million federal grant from the Centers for Medicare and Medicaid Innovation with the goal of, again, ultimately reducing smoking prevalence through increasing use of the highly successful UC San Diego Smokers Helpline, decreasing barriers to getting nicotine replacement therapy, and looking at the impact for small incentives. The funding package or the funding initiative was called Medicaid Incentives to Prevent Chronic Diseases, and we latched on in California to smoking. Dr. Tong is going to go into this information in more detail, but there's a lot of numbers, so I think it's okay if we repeat. Small incentives, the short story is that small incentives increased 6-month abstinence. 6-month abstinence is important because most people who are abstinent after 6 months are lifelong non-smokers, and that's been well studied. Compared with usual care, the use of small incentives plus mailing of nicotine replacement therapy ended up being cost savings with about a 2-to-1 return. So that's huge. We have to, well, this is obviously the ethical thing to do, the clinical right thing to do. How do we make it work it's cost savings. It's beyond cost effective. There's actually a return. And it could generate millions of dollars in cost savings to the Medi-Cal program alone. Dr. Tong is going to talk a lot about outreach and kind of the details of how you systematize this. I won't go into great detail, and I think she will allude to her other experiences with the UC system. Most important, this background information is really just, you can consider introductory. What we're trying to do, again, is to make a difference, and actually we hope to get, our group hopes to get some commitments of how we can help. There's a lot of technical assistance that Dr. Tong will talk about. Available technical assistance for Sacramento to advance smoking cessation, reduce smoking prevalence, and I would say, as a reminder, that the models that we work on, the quality improvement techniques that we use, the system changes that we make, really can often apply in a very similar, analogous fashion to hypertension control, lipid management, diabetes management, etc. So we're focused on tobacco, but the lessons learned apply to cardiovascular disease risk reduction. So with that, I'm going to transition to Dr. Tong. I'm going to give her a brief introduction. I've had the pleasure of working with her for a number of years, as I said, on this research project on this and other areas. Dr. Tong is an associate professor of internal medicine at UC Davis. She holds leadership roles across the UC system that she'll talk about in terms of smoking cessation. She's published extensively, has a number of exciting projects, and some tobacco ones you'll hear about. So Dr. Tong?
Thank you, Neal, and thank you for your leadership all these years. I don't know that I would have gotten quite as involved if it wasn't for the Medi-Cal project, and then also coming here today for the Sacramento RightCare initiative. This is a wonderful forum. It's been on my to-do list to have some sort of regional tobacco thing for some time, and when Neal said, hey, Patty said, let's go, it's like, okay, we're here. And already we're getting asked to do this in LA, so very excited that we're launching it with Sacramento first.
We're so happy you're here. Thank you.
Well, so I'm here at UC Davis, but I'm going to talk to you about this new project, California Quits, which kind of encompasses a number of things that Neal talked about, but a little bit more on the action-oriented side. And this has been, again, another thing in a long time making, but this is where we're just doing our debut as our first year of this 5-year project funded by the California Tobacco Control Program. And I just want to acknowledge also Mary Stewart, our program officer, is here today. Mary, if you want to wave. Also a benefit of being in Sacramento is the state tobacco program is here, and also wanted to acknowledge our California Quits team that's here too, if you guys want to wave. Including one of our faculty members. So just because I know not everyone may be a tobacco person like I am, just a little brief refresher about tobacco cessation treatment. I'll go into a little bit about the origins of California Quits, how it originated from UC Quits, which was funded by UC Health from UC Office of the President. I'll touch on some highlights of the mix project that Neal talked about, although you can hold up the whole supplement that we came out with last December that the California Tobacco Control Program funded. So it's a lot of info, but just know that there's more info there. And then I'll go into some system examples about providers, plans, and public health partners, some of which are in the room. And then to wrap up, I think we're going to just have everyone kind of just introduce themselves after I'm done, just to say any thoughts or barriers that they're thinking of that's on the top of their head. And then I think Neal's going to help us facilitate maybe an informal case discussion with one of our clinics that volunteered when community health in the back. So thank you. Okay, just tobacco prevalence. Everyone when I go outside of California, everyone says, "Oh, California, you're just so wonderful. You guys have no problem." You know, you've had this historical program that's passed all these wonderful smoke-free policies. You know, then I say back to them, look, we actually still have over 3 million smokers in the state, and we know we have a lot of disparities depending on where you are, who you are, and actually here in Sacramento, we've had a higher tobacco prevalence than the rest of the state. And I just wanted to show that little graphic on the left. You know, it's one of those density maps where the darker it is, you know, the higher the prevalence. In Sacramento, we've been kind of on the darker side. But Mary on our team pulled out some recent California Health Interview Survey data, which I was actually quite surprised. 2016, 2017, we're in that blue bar on that top part there, where we're actually doing better than we used to, but still higher than the prevalence amongst the rest of the state. So we have in Sacramento County 133,000 smokers, and that's not counting YOLO and everything else too, but we still have some work to go. And then when we look at the Medicaid population, and this is all across the board, Medicaid population, low socioeconomic, you know, facing a lot of barriers, they smoke at way higher rates than the general population. So in the state, it's 16.2 versus, for Medicaid, or California is Medi-Cal, and then in the state, that's compared to general prevalence of 11. And here in Sacramento County, that's almost 22% versus our general population of 11%. So again, this is one reason why we need to focus on our safety net population. We know there are disparities. And then even within subgroups, this is a busy slide, but I just couldn't resist posting this up because Mary and Bimla on our team, we also recognize that Medicaid is also about the whole life course, and maternal infant health is part of that whole life course, and a big important constituency for Medi-Cal. We actually have very high rates in Sac County of smoking during pregnancy. I mean, people quit while they're pregnant, but then they relapse once the baby's born and looks somewhat okay. And then on the bottom part, so the top part, you can see that Sacramento County is a little bit higher than the numbers in California generally. And then on the bottom part there, you can see that the folks with lower socioeconomic status, they have the highest rates. So again, we know there are some differences that we need to address. So how do you go about treating tobacco dependence? It's not just this is bad for you, you gotta quit. We know that there's a big part in terms of physiologic nicotine dependence. The way that cigarettes are engineered by the very clever tobacco industry, it's made to be one of the most addictive substances. And they basically freebase nicotine, which this is why it's so difficult to quit and why we have medications to help relieve withdrawal when people are trying to change their behavior. And we know that behavior change is important to have a plan because it's really hardwired into your routine that you get up and the first thing you do is smoke a cigarette, or after you talk on the phone after dinner, you smoke a cigarette. So how do you unlearn that? This is where counseling or developing an action plan makes it really concrete for people to integrate behavior change while they're relieving their nicotine addiction. And we know that it doesn't take just one time, it can take multiple tries to quit. That's why I like this little image at the bottom, that at first you don't succeed, quit again, because it can take, I ask docs and students, like, how many times do you think it takes to quit? And usually it's like, oh, maybe 3 times, or no, it's actually 8 to 12 times before you really quit for good. And for some folks, it's a lot harder. So this is a chronic disease, and that's the model that we should think of this. You may have heard of the 5 A's of tobacco treatment. There's actually public health service guidelines about all the evidence for how to do tobacco treatment. It's usually ask about tobacco use, so you identify the users or people who are being exposed. Advise them to quit, because even provider advice doubles the chances that they'll make a quit attempt. See if they're ready, and if they're ready, you can assist them with the quit attempt, like we said, with medications and referrals for counseling. And then arranging follow-up care, because relapse is so common. So when we're talking about quality metrics in our clinical world, this is where the 5 A's gets bucketed. The tobacco use assessment part of the quality metric is under ask, and then tobacco counseling can encompass a whole bunch of those other things, and I'll get a little bit more into this. Anyone here heard about the California Smokers Helpline? Yes? Oh, good. Okay, so this is 1-800-NO-BUTTS. It's been around for over 25 years. I like to think of it as one of the greatest secrets around, because maybe folks have heard of it. I think I saw a commercial, I'm not sure. And it's based at UC San Diego. They have a New England Journal article about how their counseling doubles the chances of long-term quitting. As a med student, I used to pass out those little gold cards up there, and that was the huge thing, because that's when you used to get credit card applications in the mail, and everyone thought that was awesome. But now we've actually advanced beyond that, and I'll share that in a little bit. But what they provide is